So Dr. Mouraru will now show how to assess secondary tricuspid regurgitation. This is a kind of tricuspid regurgitation where we cannot find any abnormalities at the level of the leaflets. This is by far the most frequent cause of tricuspid regurgitation. She will now move to the way to assess the severity of this disease and also to look at the consequences of the tricuspid regurgitation on the right ventricular cavities and annulus.
The echocardiographic assessment of the functional tricuspid regurgitation follows exactly the same sequence as for the organic. So first assessing the morphology of the valve, the severity of the tricuspid regurgitation, the consequences of on the right heart chambers, and an estimation of the pulmonary pressures. Here we are scanning a patient, a young patient, 18-year-old, who has corrected tetralogy of Fallot at the age of 6 months by a transatrial approach. And we can start with a parasternal long axis view. You can see that we see already that there is a significant enlargement of the right ventricular outflow with respect to the normal size of the left ventricle, which is also normally contracting. And there is paradoxical motion of the septum, which can be better appreciated if we place the anatomical M mode. And you can see that there is a simultaneous movement of the septum in the same direction as the posterior wall. Then, if we will go to the color flow, we will see that there is the area of the patch where there was the closure at 6 months of the interventricular defect, which has no residual leak. Here you have a different view, and then we will start to look at the tricuspid valve. For this, you need to tilt the probe towards the right heart, and you will be able to appreciate the right ventricular inflow view. At the lower part, you will see the right atrium, and at the top, you will see the right ventricle. And we see that here there is a structurally normal tricuspid valve with no visible organic abnormality, which is perfectly coapting. Then, if we add the color Doppler, we discover that there is a certain degree of tricuspid regurgitation, of which severity is not clear, and has also some variation with the respiration of the patient. This is an important aspect also from the quantitative analysis, because these variations with respiration are very frequent and may confound your measurements. So please be sure that when you acquire several cycles, you do also a mean, the average of several measurements on at least 3 cycles in a sinus rhythm, and before acquiring, you need to ask the patient to stop breathing. Then, if we rotate the transducer in order to obtain a short axis view at the level of the aortic valve, we can appreciate that the valve has a normal configuration, and there is an enlarged right ventricular outflow tract. We can also appreciate the pulmonary valve, which looks normal. And then if we add the Doppler, we will see that there is a significant pulmonary regurgitation, as it usually happens in patients with Fallot, which can also be sampled with a continuous Doppler, and you can see that there is an intense signal of the Doppler suggesting us of a significant pulmonary regurgitation. Then, if we will tilt again the probe in order to appreciate the short axis of the left ventricle, you will see that there is a flattening of the septum, predominantly in diastole. Look, so if I freeze the cine loop and then I will go frame by frame, this is diastole, and then in systole you will be able to see that the shape of the left ventricle is more round. And this is a good sign to make the distinction between the pressure overload and the volume overload of the right ventricle. In the pressure overload of the right ventricle, there is a flattening in systole and diastole of the septum, while in a volume overload, like in this case, there is a predominant flattening only in diastole here, while in systole there is overall a rounded shape of the left ventricle. Then we can move to assess the size of the right atrium. Here is a focused view from an apical approach, and we can use this very focused view to measure the area of the right atrium, to measure the volume in a single plane, but also for more advanced quantitation. If you want to perform a speckle tracking analysis, you can do it because the frame rate is very good. For instance, if you would like to measure the area, you select from the measurements area trace, and then you need to identify the endocardial border of the right atrium, and then here at the level of the tricuspid valve you need to close, and here you obtained 22, so that there is a mild enlargement of the right atrium as expected in a patient with Fallot. Here you have a 4-chamber view in which there is a significant enlargement of the right ventricle, and also visually there is a sensation of the right ventricular dysfunction that may be confirmed only after quantitating the fractional area change. If you have the possibility to perform 3D echocardiography, I would recommend it in order to provide more robust measurements of the volumes and of the global function of the right ventricle. If you want to do this, then you need to switch between the probes, the 2D and the 3D, by selecting the 4V probe and the preset. Okay. And then put your the transducer in the apical region, and then you are provided with these slices of the right ventricle automatically. This is the multi-slice display of the right ventricle, in which you can appreciate very well that there is severe enlargement of the right ventricular cavity, which has also changed in shape. The left ventricle is relatively small, and you can appreciate also the paradoxical septal motion, which is a sign of the right ventricular volume overload. Then, if you would like to use this acquisition, you can appreciate from the same data set also the morphology of the tricuspid valve. Here is the tricuspid valve as seen from the apex. The arrow that you can see here indicates your point of view, and the transversal dashed line indicates the position of the cropping plane. So we are seeing the valve from the ventricular perspective. And you can see that in one single view we have a very good delineation of the morphology, which is perfectly normal. There is no clear structural abnormality, which is characteristical and suggestive for a functional tricuspid regurgitation. If you would like to assess also the regurgitation, it can be done either in 2D or in a 3D. We can first assess it in 2D echo, and then I will switch to 3D echo in order to show to you the added value of assessing the area of the regurgitation of the jet. So changing again the probe for 2D examination. Okay. Here is the image the color Doppler flow of the tricuspid regurgitation, which doesn't seem qualitatively doesn't seem severe. However, if you would like to take a closer look, you need to zoom the image like this. And if you want to perform the measurements of the vena contracta or of the PISA, you need to take a dedicated acquisition. The Nyquist limit should be around 40 and 72. Freeze the color Doppler flow and then select the most representative frame, and then measure with caliper the most narrow region of the jet, like this. In this case is 0.7, which is exactly the borderline between moderate and severe. However, you have seen from previous images that the jet width seemed also narrower in other views. Like in this case, if you would stop it again and measure, you would find a different number, 5, 4, which stands more in the mild to moderate. In these cases, when the quantitation is not clear from measuring the vena contracta, you should go to search for alternative quantitative parameters. In this case, it's the PISA method. However, for the PISA method, you need to take a dedicated view of the valve, to decrease the Nyquist limit around 28, 29, and then to freeze the color and to search for a representative PISA. There are several cycles acquired. However, what you can appreciate from this image is that the PISA in this case is not hemispheric as one would expect or assume, but it's rather flat. And this is the most important limitation of the PISA method in functional tricuspid regurgitation. We assume when calculating the effective regurgitant orifice that the area of this orifice, the shape of the orifice is perfectly round, which does not happen in this etiology. And this can be better appreciated by acquiring a 3D acquisition with color. And you can appreciate the shape of the vena contracta in a short axis. Here. So here you have a multi-slice of the regurgitant jet of the tricuspid valve. Okay, so these are 6 equidistant slices across the tricuspid regurgitation jet, and you can appreciate that the shape of the neck of the jet is not round but has a slit-like appearance. And this explains why in several views, just by rotating a little bit the transducer, the diameters that you can measure in 2D may be very different. And this explains also why the assumptions of the PISA method do not work in this case. So this is a case in which I would not trust so much the PISA method and the quantitation with this modality, because the shape of the orifice is very, very irregular and ellipsoidal. If we want to have a different view of other parameters that help us to decide the severity of the tricuspid regurgitation, in this case, switching again to 2D echocardiography, we can assess and concentrate the evaluation into the measurement of the annulus, because the annulus is a more sensitive sign of the severity of the tricuspid regurgitation when the mechanism is functional. As you know very well, the tricuspid regurgitation, if there is no problem of the valve, has a secondary mechanism it is related to the tethering of the leaflets, the traction of the papillary muscles due to a severe enlargement of the right ventricle, like it is the case with his patient with Fallot. Or there is an increase in the pulmonary pressure. So the measurement of the annulus adds additional information on the mechanism of tricuspid regurgitation, and it is also the measurement that it is required by the surgeons in order to decide whether the valve should be repaired or not. This needs to be done in the 4-chamber view in diastole, and the normal values are 35 or 21 centimeters per meter square if you need to index them to body surface area. In this case, the annulus is not very dilated, it's 36, so probably the mechanism of tricuspid regurgitation is more related to the tethering of the leaflets rather than the annulus dilation. In order to prove this, you can measure the tenting area and the coaptation distance. The tenting area should be measured in mid-systole, and it's the area of the tent formed by the leaflets, which are closed, and the annulus plane, like this. Here it's 2 centimeters square. When this area is larger than 1.7, it is a very good predictor of recurrent tricuspid regurgitation if the patient would go to surgery. So this is also a prognostic marker in terms of postoperative outcome, and should be done in every patient that will be subjected to cardiac surgery. Other indirect signs of tricuspid regurgitation severity are the amplitude of the E wave that you have here by the pulse wave Doppler. You can measure it, and here the amplitude is 0.63, so it's not supportive for severe tricuspid regurgitation because the cutoff is 1 meter per second. And finally, as I said in the beginning, we should always assess also the pulmonary pressures. The pulmonary pressure with a continuous wave Doppler across the regurgitation. Here, if you would measure the maximal velocity, is 29-30 millimeters per meter square, to which we need to add also the pressure estimated in the right atrium. For estimating the pressure in the right atrium, we need to scan from a subcostal view and assess the inferior vena cava. Then we can switch to the subcostal view, and we will ask the patient to lean on his back. And we can appreciate the tricuspid valve and the right ventricle. If we would like to measure the thickness of the right ventricular wall, we need to zoom the image and to freeze it in diastole and to measure it at the level more or less at the papillary muscle level, like this. It's 6, which is close to normal. The normal value is 0.5. Then for assessing the hepatic flow, you need to obtain the view of the inferior vena cava, and then to open the hepatic vein, to put the pulse wave Doppler into the opening of the hepatic vein, and then you will obtain the pulse wave Doppler envelope of the hepatic flow with a systolic blunting and with the diastolic wave, and then reverse after atrial contraction. Then The last thing that you should do is to assess the dimensions and the collapsibility of the vena cava. If there is no spontaneous collapse, you should ask the patient to have a short, very short breathing, as called a sniff test. So please breathe. And if you will put the M mode, you will see that there is indeed a collapse, so meaning that the pressures in the right atrium are not increased. So after this overall examination, I would conclude that the mechanism in this case of the tricuspid regurgitation is a functional one, and there is no criteria of severity, so we can conclude for a moderate tricuspid regurgitation. Again, this conclusion does not come from a single number, but from integrating information by morphology, Doppler, and continuous wave Doppler, and also related to the size and the response of the inferior vena cava.
So we see that it's very important to keep in mind that we can only use semi-quantitative data, that it's very important to assess not only the severity of the valve disease but also of the consequences of this valve disease, and to take into account the clinical context of the patient.